Thank you, Matilda, for the opportunity to talk today. I really appreciate the chance to talk about phenotyping, a topic that's very near and dear to my heart because I do believe it's changed for the better the way we are working with patients to help them find the most successful treatments for them. So my name is Jill Osborne. I've been a support group leader for 31 years. That means, yes, I am one of the old guard, along with Jane. Built the first website on IC in 1994, and I've been a research panelist and served on guidelines committee, written books, but many people know me because I do live support group meetings on YouTube and Facebook almost every Sunday. So what's our topic today? Phenotyping and the diagnosis and treatment of IC. So what do we know? Well, that the IC patient population is very diverse, including age of onset, culture, profession, and history. We know that a one-treatment-fits-all approach, such as Elmeron, simply does not work for the majority of patients. And we also know here in the United States that we've invested more than $100 million in IC treatment research, and only one study was found to be significantly successful. That is the pelvic floor physical therapy study. So I ask you, if physical therapy was successful when other bladder therapies are really not, is this really a bladder disease in most patients? Think about it. Now, early on, 20 years ago, 25 years ago, 30 years ago, researchers and clinicians agreed that there were two distinct patient groups, Hunner's lesion patients and patients without Hunner's lesions. In 2009, Drs. Dan Shoskis and Curtis Nickel were the first to come up with a phenotyping system that they called U-Point. They encouraged the development of treatment plans based upon 6 key domains: the patient's urinary symptoms, their psychosocial functioning, do they struggle with depression or anxiety, their bladder findings specifically, the presence of infection, if any, their neurological health, and or their pelvic floor muscle health. And then based upon their findings, they asked doctors to create individualized treatment plans. Now, interestingly, U-Point was adapted into a new system called Int'l, and that is currently recommended for use in the Canadian Urology Association guidelines for IC-BPS, not really used too many other places. In 2015, Dr. Christopher Payne from Stanford University, he ran the IC research program at Stanford for many, many years, proposed 5 phenotypes for IC. His rationale was that a diagnosis of IC doesn't give the patient or provider a clear treatment pathway. As a model, he asked us to look at the far more in-depth diagnoses provided in cancer care, arguing that they have a clearly identifiable treatment plan that IC patients lack, and that with phenotyping, IC patients can receive a more accurate diagnosis and effective treatment plan. He proposed 5 phenotypes, but suggests there are probably more. So in his system, Hunner's lesion is the first phenotype or subtype. Obviously, these patients have profound inflammation on the bladder. They have extreme symptoms, extreme diet sensitivity. We have multiple studies now that have found virus in the urine of patients with lesions, including polyoma BK and Epstein-Barr. And we also have a new proposal for a new phenotype focused on uterosacral ligament laxity, also known as posterior fornix syndrome. His second phenotype is bladder wall driven, and in this group there are 3 variants. The first thing we're going to look for is chemical injury. So these are the patients whose symptoms begin with chemotherapy, or while they're using ketamine, or if they're drinking a massive amount of soda or coffee, etc. The bladder, like any other part of the body, can be injured, and generally it's injured through toxic chemical exposures. In this group, we're also going to look at the quality and health of the skin based upon estrogen levels. If you have a patient whose symptoms began as they've gotten older, or if they've had total hysterectomy, or if they've been on Lupron for endometriosis, or even if they've been on birth control, that reduction in estrogen will directly affect the health of the bladder wall. It will reduce the gag layer and make that bladder more vulnerable. That is not a disease process. That is simply dryness. And one of my personal causes is to find those patients who have been told they have incurable disease and give them the comfort of knowing that no, this isn't a disease at all. This is simply estrogen atrophy. And of course, we also want to look for chronic infection. Bacterial, fungal, viral, Lyme, even black mold infections have the potential of triggering some bladder wall symptoms. The third phenotype is pelvic floor driven. So these are patients whose symptoms began after some sort of pelvic trauma, a car accident, or falls. They may have a history of childhood or extreme athletics or even dance. They may have suffered injuries during childbirth. They may have been a victim of sexual abuse. Their symptoms may have begun at a young age. And the terrible toll of tight pelvic floor muscles is pelvic ischemia or ischemia. Payne's fourth system is pudendal neuralgia. These are patients who have positional symptoms. They're fine when they stand, but when they sit down, it hurts. When they bend over, it hurts. This is being driven by nerve injury or dysfunction. We often see this when tight muscles compress nerves. A good example of this is sciatica. That's absolute proof of muscle squeezing nerves. But it can often happen from bike riding, horseback riding, motorcycle riding, or even sitting for long periods of time. And in Payne's fifth system, we see central sensitization. These patients have widespread pain, IBS, IC, vulvodynia, TMJ, migraines. If they have two or more of those chronic overlapping pain conditions, then that suggests to us that we have a central nervous system injury or trauma. These patients are going to have extreme sensory sensitivity, skin, smell, light, taste, sound. They may have food, chemical, or drug sensitivity, and of course they may have anxiety disorder and catastrophic thinking. This is the group that we now believe is tanking the vast majority of studies out there, because you cannot expect a treatment designed to treat estrogen atrophy to be effective for somebody with central sensitization. So what are the advantages of the Payne system? Well, it's ideal for use in clinic. It's simple and easy to explain. It provides an intuitive treatment plan customized for each patient. It helps the patient understand the value of a multimodal approach and validates the use of therapies such as topical estrogen for estrogen atrophy or antidepressants to calm the central nervous system. And it puts self-care and mind-body medicine into context without offending patients by suggesting that their treatments are all in their head, or their symptoms are all in their head. Now in 2022, Dr. Curtis Int'l proposed 9 phenotypes for IC. His first group is the inflammatory group, also known as the Hunter's lesion group, and he gives treatment suggestions that I won't go through right now. You can come back and read those later, but just understand that inflammatory Hunter's lesion group is a very, very distinct group. His second group is infection mediated. He believes that there are patients who have a history of recurring UTIs and that these patients may be experiencing a bladder hypersensitivity syndrome secondary to the infection. He advocates for the use of antibiotics used directly in the bladder via bladder instillation. Brilliant idea. And enthusiastically promotes new UTI vaccines. His third group is a widespread pain group that he calls neurogenic hypersensitivity. Obviously, therapies are going to be focused on calming the nervous system. His fourth group is new. He believes that there is an allergenic group. These patients have respiratory, environmental, or dietary allergies. This is easily identifiable during a cystoscopy by gently poking the bladder with a cystoscope to look for a little bump or mucosal wheal. These are the patients who are going to do the best with antihistamines. His fifth group is pelvic floor driven. Their therapy is going to focus on restoring muscle health, relaxing tight muscles, etc., etc. His sixth group is primary storage symptom syndrome. These patients run to the restroom due to pain on bladder fill, and they may benefit from the use of antimuscarinics or bladder training or Botox. His seventh group is also a new phenotype. This is urethral pain syndrome. This pain is constant, episodic, or associated with urination. Sometimes it's their only symptom. And he believes that these are some of the most difficult patients to treat. Suggests using topical lidocaine, vaginal estrogen, low-dose amitriptyline, etc. His eighth group is sexual pain. Believes that that needs to be addressed. Treatment is usually pelvic floor physical therapy. And his ninth group is IC flares, making sure that physicians understand that flares require additional care. What's the advantage to the nickel proposal? It takes a deeper dive into potential causes of pelvic pain, particularly urethral and sexual pain, and he reminds us all that flares require treatment, and he provides wonderful recipes for treatment that are thorough and customized for each group. Now, in 2022, the American Urology Association released their updated guidelines for IC, and this was the first time that they included phenotyping, but they combined a bunch together. So they've got a bladder-centric group that includes Hunner's lesions, small bladder capacity, or pain that improves local anesthetics. So we're going to see the estrogen atrophy patient in this group and the chemocystitis patient in this group. They have a pelvic floor-driven group. We now believe that 80 to 85% of patients fit in this group. The treatment goal is to restore normal muscle tone and to resolve painful trigger points. And then, of course, we've got the widespread pain phenotype, and these are the patients who have multiple pain conditions where we're going to focus on calming the central nervous system. AUA says no single treatment works for the majority of patients. The treatment should be tailored to the specific symptoms or phenotype of each patient. And if a patient is not responding to multiple treatments, the diagnosis of IC should be reconsidered. AUA only has 2 treatment recommendations: that Hunner's lesions be identified and treated promptly with lesion-specific therapies, and that patients with pelvic floor tension should be referred to physical therapy immediately, and all other treatments are considered options. So are there other phenotypes? Yeah, I think there are. I think there's an autoimmune phenotype. These are the patients who have lupus and Sjogren's or any other autoimmune disorders. Last research I looked at said that was about 3% of the IC patient population. We have a new proposal adding posterior fornix syndrome or USL laxity as a distinct phenotype for IC and for chronic pelvic pain. I do believe that there is a hormone dysfunction group because you always see patients who either flare when their estrogen is very high or flare when their estrogen is very low, but more importantly, when their hormones are stabilized, their symptoms stabilize. I'm really curious about that. And last but not least, I do believe that there is a urinary biome phenotype based upon the research of Dr. Ann Ackerman and her discovery of lactobacillus inners in patients who have bladder wall-driven pain. I did want to share, for those of you who have been around, our most well-known supplement, Pre-Leaf, which has helped thousands, if not millions of patients eat more foods without irritating their bladder. They are just launching a brand new supplement called P-Leaf. This uses palmitoyl ethanolamide based upon the 2019 IC study showing that it significantly and progressively reduced pain and discomfort. So we're pretty excited to see this. So anyway, thank you so much for the opportunity, and I'm really happy to take any questions that you might have. Thank you.